Welcome, colleagues, and thank you for attending today's session on freediving, and that we've titled The Aquatic Human. I'm Stephen Chung, and again, this series is co-organized with Tadej Debevich from the University of Ljubljana in Slovenia and Chris Tyler at Roehampton in the UK. And today, again, we're all going to be talking about freediving, breath holding, and underwater physiology, which is another new kind of area for us in our ICEE series. So thank you in advance for our two speakers for joining us and giving us talks about this. And as you know, we've had this series of talks since April in 2020, shortly after the lockdown, and they are all available, all of the talks, along with student guides for most of the talks at the website ICEE2021.com. And if you click in the past events, you will see, again, all of the talks. And again, the underlined text there means that there is an instructor guide for that talk specifically. And besides those, I've also started a new initiative of weekly Wednesday kind of short science videos that are about 3 minutes long. They're really about different aspects of environmental physiology, either highlighting specific papers or discussing different concepts. The idea is really to improve and promote our science communication of environmental physiology. And my hope for these is that it won't just necessarily be me making the videos, but that will almost build a wiki community of different scientists talking about different ideas and contributing to this. And this idea of science communication, I think, is really, really important for us. And it's actually going to be, looking ahead to next session, is going to be the entire focus of our next talk on March 4th with the sports science journalist and author Alex Hutchinson. And the title for his talk is going to be What I Wish Scientists Knew About Science Communication. So it's really going to be about how he tackles ideas in terms of deciding what ideas to discuss, and how he works with kind of scientists to help communicate their messages, and also what we as scientists can do to help writers and journalists like him do his job better. So definitely encourage you to attend in 2 weeks' time. But again, to keep the introduction short, most of us have been in these series before, so you know how they work. We'll have two speakers. The first speaker today is Dr. Anthony Bain from the University of Windsor here in Canada, which is just right across the border from Detroit in the US. And he will be talking about cerebral vascular physiology as it applies to breath holding. How do you breath hold? And also the challenges and the trainability of that. They'll be followed by Alex Patrician, who is a PhD student at UBC Kelowna, or UBC Okanagan in Kelowna. And his talk will be more about the vascular aspects and the actual kind of depth and diving to deep levels. So as always, we have the Q&A tool that I encourage you to put your questions in, and rather than the chat tool, because after each talk, I will moderate a short kind of Q&A with the individual speaker. At the end, we'll also have a roundtable kind of panel discussion. So again, without further ado, I will pass that on to our first speaker. I'll stop sharing my screen. And I'll pass that on to Tony Bain, and he can share his screen.
All right. All right, we working?
Yep.
Perfect. Okay, so let me just minimize this here. There we go. Thanks, Stephen. I want to reiterate the fact that when we were talking earlier, I think it's a fantastic initiative getting these virtual seminars and continuing the trend of, or at least the the history of the International Conference of Environmental Ergonomics. So fantastic thing to put together. All right, so I'm going to be, like Stephen said, I'm going to be talking about the control of breathing and then touch on the cerebral vascular function. So before I do that, I just want to somehow advance my slide. Hello. There we go. Okay, so I want to give a brief background of the aquatic human. And I think it's funny that Stephen mentioned how this is a new topic for the environmental ergonomics. And it's a new topic to us, but it's really not a new topic for humans. So you can go back several centuries. And so circa 400 BC, there's accounts of freediving for sea sponges, and this was generally around Greece. And then the well-known pearl divers, the ama divers in Japan and Korea. In fact, there still is a small group of, they're all female pearl divers, the ama divers, that continue the tradition in Japan today. And so that was several hundred years ago, or several thousand years ago, sorry. So we can fast forward to today in modern times, and now the freediving has really become popular based on the 1988 movie, The Deep Blue, and that really popularized freediving. But today there's freediving for recreation, so spear diving is very popular. Cinematography is very popular. You don't have the bubbles, so the advantage of actually filming fish underwater without the obtrusive bubbles. And then, of course, the competition aspect of freediving, and that's really what we are going to talk about today. So in apnea condition or competition, there are 10 established disciplines by ADA, which is the regulatory board for apnea competition. But those 10 disciplines, you can really break them down into 3 sort of unique disciplines. So first you have static disciplines. Really, in a static discipline is just holding your breath for the longest period of time. Generally it's face down underwater, just like this individual here. The current world record for that is 11 minutes and 35 seconds, at least recognized by ADA. I do acknowledge that there is a Guinness World Record that is, I believe, closer to 12 minutes, but that is not recognized by ADA. So 11 minutes, 35 seconds, and that is without oxygen. Okay, so as soon as you pre-breathe with oxygen, that number goes up to around 25. So I will chat about that in this seminar. So next you have dynamic disciplines. Dynamic disciplines simply relate to how far you can go in a pool. So how many laps basically you can attain in a pool. Several different disciplines, so with fins, without fins. The current world record for with fins is 300 meters. And so if you could just consider one lap of a pool is 25 meters. So you can do the math on how many times they're going back and forth there. So next, which is really popular, the depth disciplines. So currently the world record for a depth discipline is 130 meters, and that is with a fin. Now within depth disciplines, you also have what's called no limits. And that's basically they're going down on a sled. And here they can attain some really deep dives. So 214 meters is the current world record for that. And the unique physiology associated with the depths, that's what Alex Patrician is going to talk about. And I think that's really, really interesting, but it really is sort of 2 unique stressors here. We have the stress of just holding the breath, especially in the static disciplines, but we also have the stress of the barometric pressure, so the depths. So I'm going to talk about the stress of holding the breath, and like I said, Alex is going to talk about the stress of the depths. Okay, so presentation overview. First, I'm going to briefly touch on the mechanisms of the elite breath hold breaking point, and then we're going to talk about the cerebral vascular function and specifically the impact of blood gases. Okay, so just a little picture down here to acknowledge all this work was done in the Croatian freedivers, and so of course we are completely indebted to their continued support. They have allowed us to come back for 5-6 years now and continue to do experiments on them. So we're extremely indebted to the Croatian national apnea team. Okay, so blood gases have underlined because that's, it's sort of the umbrella for both the mechanisms of elite breath hold breaking point as well as the cerebrovascular function. So I just quickly want to walk you through the blood gases during a standard breath hold. So this is a static, dry static apnea, meaning dry, we're not in the water. Static, we're not moving around. So just lying on a bed, just like this individual here. So on the left side of this figure, we have our partial pressure of arterial oxygen in blue. And then the right y-axis is the partial pressure of carbon dioxide in the black. And this is over a breath hold time of approximately 8 minutes. So quite a long time, especially for a dry static apnea. So as soon as you have facial coolant or you're in water, you can actually increase the breath hold time because you are stimulating the mammalian dive reflex. Okay, so nonetheless, so let's look at these blood gases. So first off, thing to notice here is you have an initial dip in the carbon dioxide concentrations, and that's because most often these freedivers will hyperventilate a little bit before they start their breath hold. And so that's why you get this little dip. But then eventually that they're holding their breath, so this the CO2 starts to increase, and then after an initial increase, because of the hyperventilation, it starts to decrease, okay? Now, eventually they get to a point which is called the involuntary breathing movements. And this is where you or I, unless you're a freediver in the audience, but at least this is where I would break my breath hold if I'm motivated. Okay, so an involuntary breathing movement is the point at which the stimulus to breathe is so strong that your diaphragm will actually contract. I've got a quick video of here what that looks like. So here we have our freediver on the bed, and he's undergoing these, we'll call them very mild involuntary breathing movements, but you can actually see him catch his breath in his mouth, okay? And he doesn't breathe. So his diaphragm contracts, so we go through the respiratory, at least cycle without ventilation, and he catches that breath in his mouth, and then he continues to hold his breath. Okay, so of course, this is unique to freedivers, right? So these freedivers become much more hypoxemic, shown down here, and much more hypercapnic. So very high levels of CO2, very low levels of oxygen. So with that, it sort of begs the question, well, there must be differences in the breakpoint mechanisms with the untrained freediver and then the trained diver. So let's quickly just look at the basic control of breathing mechanism. So here we have Calvin here, and he's holding his breath, so there's a drive to breathe. So first off, you have your respiratory rhythm generator, which is the central controller, let's say. So this is in the medulla, the pre-Butzinger complex. So that's always generating a signal telling your body that I need to breathe. Okay, so, and next we have our sensors. There are several different sensors across the body, but the most prominent are sensors coming from the lungs and then the chemoreception. So sensors for hypoxia and hypercapnia. So that's in the brain for hypercapnia primarily, and then for hypoxia and a little bit of hypercapnia. This all happens at the carotid bodies, okay? Now, the moment-to-moment regulation of the control of breathing generally is centered on small changes in chemoreception related to levels of CO2. So, and we know in the naive breath holder that the break point, so the point at which you break your breath hold, is primarily related to the hypercapnia. So what we did in the first experiment in Croatia was, well, we wanted to block that stimulus, or at least inhibit that stimulus, and we could do that using infusion of low-dose dopamine. And that's been experimentally shown to actually inhibit the glomus cells of the carotid body. Okay, so you no longer get that hypoxic and hypercapnic. You still do have central chemoreception, but you're largely inhibiting the hypercapnic chemoreception. So we did that in the elite breath hold divers. The experimental design, we'll quickly go over to a randomized control study. We have a placebo and then low-dose dopamine, so they've got volume-matched saline. So after a 20-minute wash-in period, each diver went through a maximal dry breath hold. And then after 15 minutes rest, we did a ventilatory response to hypoxia and hypercapnia. The reason for this ventilatory response is just to assure that the low-dose dopamine was in fact inhibiting the chemo reflex, so the ventilatory chemo reflex. Okay, so the outcome variables, of course, are apnea duration. So this is a maximal apnea, the onset time for the involuntary breathing movements, and as well the arterial blood gases. During the ventilatory response, we clamped their blood gases to a PaCO2 of 46 millimeters of mercury and then a PaO2 of 39 millimeters of mercury. And the reason why we did that is it sort of mimicked the latter 3/4 of a maximal apnea. So we're sort of mimicking what happens, at least at the, you're starting to get to the tail ends of one of these maximal breath holds. Okay, so first I'm going to show the data for the ventilatory slope. So the ventilatory chemo reflex. And as you can see, we were successful in inhibiting the ventilatory chemo reflex. So here we have dopamine, and then on the left we have our placebo, and the ventilatory slope is much lower for the dopamine compared to the placebo. And on average, that was a 27% reduction in the ventilatory slope. So next, what about the involuntary breathing movements? Well, that interestingly quite followed the ventilatory slope. You had approximately 29% longer time before the involuntary breathing movements with the dopamine. Okay, so it delayed the onset of these involuntary breathing movements. But interestingly, despite that, the maximal apnea durations were very, very similar, right? Or at least they were statistically similar. There was no difference in at least between the placebo and the dopamine. So that got us thinking, well, next let's look at the blood gases. So first on the left here, we have our CO2, and there's basically no difference in the CO2 levels, so the arterial CO2 levels. The end apnea is around 53, which is very hypercapnic. If you can recall from textbook, normal capnia is around 40 millimeters of mercury. And now the NPaO2 was again identical. Okay, so they basically overlapped. And what's interesting here is the end apnea partial pressure of arterial oxygen was approximately 30 millimeters of mercury. Now that is quite unique because that is right around the threshold for consciousness, and it's right around a P50. In other words, a 50% oxygen saturation, which generally is around 27 millimeters of mercury. So in the elite divers, we think that the chemoreception really isn't, although it's still present, although you still have these signals that are certainly present, they're not the end mechanism for the breaking point, right? The divers are able to just simply endure. They're very, very strong. These are athletes. So they're able to endure these signals. And so much so that it comes down to basically a critical level of hypoxemia before loss of consciousness. So that is in the elite breaking point. And this was a novel finding because before this, and I think this was published in 2016 or something, but before this, it was thought that no diver could basically hold, or no human could hold their breath until they lose consciousness. And we know from the elite divers that that is absolutely not the case. Many of the divers we worked with could absolutely hold their breath until they lost consciousness, but they've trained themselves to basically know exactly when that point would be, right before they lose consciousness, to then break the breath hold so that, at least in competition, they're not disqualified. Okay, so if it's a critical level of hypoxemia that is driving the breaking point in these elite athletes, well, then the question is what determines the elite apnea breaking point in the absence of hypoxia? So in a hyperoxic breath hold. So a hyperoxic breath hold or apnea is, you can easily do it if you breathe 100% oxygen for approximately 15 minutes before you hold your breath. So all the air in your lungs is oxygen, right? So generally breathing in the atmospheric air, it's 79% nitrogen, which is inert, but you shift that over to oxygen. David Bain was probably the first one to popularize this. He claimed that he had a breath hold of 17 minutes. Of course, he is a magician and he tricked the world. He pre-breathed with 100% oxygen. The current world record right now which is held by our good friend Budimir. He was one of the subjects. It's 24 minutes, so 24 minutes and 11, or it's 24 minutes and 11 seconds. And this is a Guinness World Record because the pre-breathing, the hyperoxic apneas are not recognized by ADA. So it has to be a Guinness World Record. Okay, so in this case here, so with 100% oxygen breathing, you don't develop any hypoxemia during the breath hold. Even at the very end of the breath hold, you're not hypoxic whatsoever. But the breath hold is very long. Your VCO2, your metabolism is still present, so you develop severe hypercapnia, right? You're still developing that CO2. And also you have a decreased lung volume. And the reason for that decreased lung volume is because there's a disproportionate transfer of oxygen from the lungs to the capillaries, to the blood, compared to CO2 release from the pulmonary capillaries to the lungs. So in the end, over time, and over 20 minutes or so, you get a decreased lung volume. So we wanted to look at these two factors here. So a simple experimental design, this was just an observational study, or a correlational study. We first did a forced vital capacity in these divers using spirometry. And then we got them to do a maximal hyperoxic apnea. And after that, we did a CO2 ventilatory response. So the idea here was the forced vital capacity was to observe the influence of lung volume, whereas the CO2 ventilatory responses was to observe the influence of hypercapnia. Okay, so first let's look at the influence of hypercapnia on the left here. And so we have the hyperoxic apnea duration as the y-axis over our ventilatory response to CO2. And it's pretty obvious here that there's no relation, right? It's a pretty flat line, R squared of less than 0.001. This means that the hyperoxic apnea duration really has no correlation, is not correlated whatsoever with the individual diver's hypercapnic ventilatory response, okay? But when we look at the lung volume, so now we put forced vital capacity, now we see this nice relationship, okay? So meaning that the hyperoxic apnea duration is related to the total lung size of the diver. Now, of course, this is not cause and effect. This is a correlational study. But perhaps it shouldn't be too surprising that the lung volumes really determine how long you can hold your breath, at least with a hyperoxic apnea. And it shouldn't be surprising because when we look at the divers that are actually doing this, I'm going to show a quick video of Alex Segura here. He held the record until Budimir beat it most recently. So this is at the end of his 24-minute breath hold, which was the record at the time. And just watch what happens right at the end when he comes in. So when you or I break a breath hold, think about what happens and then watch what happens with Alex Segura here. So slow the video down right around the 24-minute mark when he's going to break the breath hold. Okay, so he's going to come back up. Right there, he breathes in, right? He's not breathing out. So normally, if you were to hold your breath at this point, take a breath, deep breath in, as big as you can. That's what they do before they start. When you break your breath hold, you exhale, but not during a hyperoxic apnea. They're actually inhaling because they're right down to their residual volume, right? In this case, if he held his breath any longer, you actually run the risk for a lung collapse. So it can actually be quite dangerous in that respect. So it's really no surprise that it's the lung volumes that are determining the hyperoxic apnea duration. Okay, so we have that lung volumes here. All right, so now let's shift focus. Let's look at the cerebral vascular function and the impact of these blood gases. So with the cerebral vascular function, I'm just going to highlight these four variables here: the cerebral blood flow, the oxygen delivery, the oxygen extraction, and then the metabolic rate of oxygen. So quickly on the methodology, we used ultrasounds to determine the cerebral blood flow. So this is of the vertebral artery and then the internal carotid artery. And it's very convenient to use ultrasound because it gives us quite a high temporal resolution, which is what you need because you really want to get the blood flow right at the end of the apnea. Of course, we get diameter and velocity, and therefore we can calculate the global cerebral blood flow. Okay, so the cerebral oxygen delivery, we cannulise the radial artery to get the arterial oxygen content, and then we times that by the cerebral blood flow, and that gives us our oxygen delivery to the brain. The cerebral oxygen extraction, well, in this case, we had to cannulate the internal jugular vein, and then we get a difference in the arterial and the cerebral venous oxygen, and that difference will give us the cerebral oxygen extraction. And then the metabolic rate is basically the blood flow times the extraction. So this would be Fick's equation here. All right, so what did we see? Well, this is this graph that I'm going to show you is actually an average of 4 different studies. Okay, so this is over 4 different studies. So let me just orient you here to this figure. So we have our percent change on the y-axis from baseline. So 0 would be our baseline. I had to put lung packing first down here on the x-axis, sorry. And I had to put lung packing because there's a big hemodynamic shift that happens when these divers take in this deep breath of air, and then lung packing, basically they're taking more and more air in on top of their total lung capacity. Okay, so they're using, it's called glossopharyngeal insufflation. All right. And then over the breath hold duration, so to normalize across the participants, we have to have a percent of breath hold. So first, let's start with the cerebral blood flow. Notice what happens with lung packing. You almost have a 50%, well, it's around 40% reduction in the cerebral blood flow. And that is because lung packing causes a very high intrathoracic pressure, which in turn reduces your venous return. So you reduce your venous return, you reduce your cardiac output, and then you'll reduce your blood pressure. So this reduction here in cerebral blood flow is completely attributed to a reduction in cerebral perfusion pressure. Okay, after though, so it starts to go back up, right? Start to go back up at around 40%, you're back to your baseline. And then in some people, you have basically a doubling of the cerebral blood flow right at the end of the apnea. So now let's look at the delivery of oxygen. Well, right at the start, it follows the cerebral blood flow, okay, and then starts to go back up. And interestingly, it actually goes up above baseline and up until about 80% of the maximal breath hold until it starts to decline, but it never goes back below the baseline at the very end. What about the oxygen extraction? Well, at the very onset, to compensate for this reduction in delivery, you have an increase in extraction to maintain consciousness, but then it starts to go down and it keeps going down. Now, what's interesting is it doesn't reach 0 when the delivery reaches 0% change. It's around -25. So if you have a mathematical mind now, you can probably already figure out what happens with the cerebral metabolic rate of oxygen. It stays constant until right at the end when there's a disconnect between the delivery and the extraction. So you have this cerebral hypometabolism. And perhaps this shouldn't be surprising, this hypometabolism, because if we look at the extraction down here, so this is the arterial oxygen, the PO2, and then the cerebral or the jugular venous PO2, there's basically there's a very, very small gradient. So there's barely any extraction going on here down at the very end of the apnea. So this hypometabolism, we think it actually might be protective, right? So you have cerebral hypometabolism. It could delay the reduction in cerebral PO2 before a loss of consciousness. So it could entirely be a protective mechanism. We, of course, wanted to look at what those mechanisms were. So is it related to the severe hypoxia? Is it related to the severe hypercapnia, or is it related to a dive reflex? Well, we don't think it's related to a dive reflex because remember, these were dry breath holds. And so there's no facial cooling. And we know that the trigeminal nerve stimulation with facial cooling is really what emphasizes this dive reflex. So we didn't have that in this case. So we really pointed to the hypoxia and the hypercapnia. So we developed the next couple of experiments here. Don't focus too much. I know this is a messy figure, but we have our basically in bold here are 4 different time points where we actually measured the metabolism. So at baseline, right at the start of the apnea, at the start of the first involuntary breathing movement, and then at the very end. And we did that over 3 apnea designs. So the first apnea is considered a normal apnea. Okay, so in this case, we're developing severe hypercapnia and hypoxemia. The second apnea is with prior hyperventilation. So in this case, because they hyperventilated down all the way to about 20 millimeters of mercury CO2, they still develop these severe hypoxemia, but at the very end here, they're basically normal capnic, okay, because they've allowed this large buffer for the CO2 to rise before it goes above the baseline values. And then the third apnea design was with prior 100% oxygen. So in this case, they're never developing hypoxemia, right? But they will develop the most severe levels of hypercapnia. So with these 3 designs, we basically have partitioned out the unique influences of blood gases. All right, so just to confirm our experimental design, when we look at the blood gases here, we have our arterial saturation of oxygen on the y-axis over the baseline, onset time of apnea, the first IBM, and the end. As expected, we have no change in with the hyperoxic apnea, right? We're 100% saturated all the way through. And then we have reductions in the other 2, prior hyperventilation and normal apnea. And likewise, with the partial pressure of carbon dioxide, we had some divergent variables, which we were going for. And really just to highlight the end here, the end of the apnea, with a normal apnea, we have a delta change from baseline of 11 millimeters of mercury. Prior hyperventilation, very small, almost negligible, 2.5 millimeters of mercury. And with the hyperoxic apnea, wow, we had a big increase in the carbon dioxide levels of 17.5 millimeters of mercury. So now, again, we've got these vast differences in carbon dioxide concentrations and these vast differences in the oxygen concentrations. So let's look at the metabolism. So first off, the serial metabolism here, so we have percent change. With the normal apnea, so this is a normal one first, we had about a 25% reduction in the serial metabolism. And I already showed you those data, right? And this was with an 11.1 millimeter mercury increase in the partial pressure of carbon dioxide. We expected to see that, no surprise here. But with the prior hyperventilation, where they really didn't become that hypercapnic, there was basically no change in the serial metabolism, at least no significant change in the serial metabolism from baseline. And then when we look at the hyperoxic apnea, well, now we have the largest reduction in the serial metabolism, and it's very pronounced, as you can see, down to close to 50% in some people. Now, just a side note here, this is a big reduction in serial metabolism, and they are feeling a little bit euphoric, a little bit, the way they put it was they just felt out of it, and it's probably related to this big decrease in the serial metabolism. And again, here we had the biggest increase in the partial pressure of carbon dioxide, but we didn't have any hypoxemia. Okay? In these 2 conditions, we had hypoxemia, different variables of carbon dioxide. In this condition, we had a very high level of carbon dioxide, but no hypoxemia. So that, of course, suggests that it's the carbon dioxide that's driving the hypometabolism in an apnea. So what could be the mechanisms? Well, these are just speculation, but I just wanted to put it out here for discussion. There are data to suggest that if you have an increased extracellular adenosine, which apparently does happen when you have a decrease in pH, so with acidity, with the increase in CO2, well, that can cause neurodepression. On top of that, or linked with that, is you have a reduced glycolytic activity. So you're reducing the activity of PFK, phosphofructokinase, which is a rate-limiting enzyme in glycolysis. So of course that will in itself reduce the metabolism. And lastly, I just want to put this one here because this is the environmental ergonomics seminar. And historically, we like to talk about temperature. So there is an idea if you increase the serial blood flow, remember there's about 100% increase in some of these people, well, you're going to reduce the serial temperature by simply convectively cooling it. And through a Arrhenius effect or Q10 effect, you could actually get a reduction in metabolism. I don't think that's the case. I just wanted to put it here, just for future thought. Okay, so quickly to summarize, in the elite breath hold divers, the normoxic apnea, we found that it's a critical PO2 before loss of consciousness. With a hyperoxic breath hold, it's related to lung size. We found that the cerebral metabolic rate of oxygen is decreased near the end of an elite apnea, and we found that hypercapnia is necessary for the reduction in the cerebral metabolic rate of oxygen during an apnea. Now, one thing we don't know is whether it's sufficient. And so that will bring us to our next few studies, hopefully in the future, where we have hypercapnia in the absence of apnea to see if that will actually reduce the metabolic rate. Okay, so that's it for me. Of course, we could not do this work without the support of the Croatian apnea team. This work was done when I was at UBC with Phil Ainsley driving this, and Chris Willey was actually the first one to make contact with Željko, the collaborator from Croatia. And of course, the clinical support by David McLeod. So that is it for me. And Stephen, I'll bring it back to you.
Great. Thank you for that, Tony. Excellent talk and really fascinating kind of breakdown of your different research designs in terms of trying to parse out each individual mechanism. So really well done on that. Maybe I'll just start with a really general question. You mentioned lung packing, and we've probably all seen kind of videos of kind of divers doing that. And you talked about kind of some of the physiology of it, but can you just talk us through what it is? Like what is actually happening there when people do that lung packing maneuver?
Yeah, it's probably easier to show just by a video. But I guess I'm on video here. So they'll take I can't do it, mind you. They'll take a deep breath in, so they'll all the way up to essentially their total lung capacity, at least what we would consider total lung capacity in a normal spirometry test. But once they're at that level, then they use their glossopharyngeal muscles to kind of pack more air into the lungs, and in turn just really expand the lung parenchyma and get a maximal amount of air in there. Not all divers do it, and it's generally reserved for static apneas. And sometimes they'll hyperventilate a little bit with it. So maybe Alex will talk a little bit more about that during the depth dives. But yeah, basically they're trying to get the largest lung volumes possible before they start their breath hold.
Yeah, because I was always wondering about trying to, it almost looks like they're kind of doing more little swallows of that. So okay, that makes sense what they're trying to do there.
Yeah, but they're packing it into not their stomach, into their lungs, right? So, yeah.
Okay, and then we have a question from Devin Phillips, and fantastic data and presentation. The dopamine apnea data is very interesting. Do you think there may be an individual dose response in terms of the hypoxic VE response to dopamine infusion? And is there data to show sustained and effective carotid body inhibition with this severe kind of hypoxic state?
Yeah, it's fairly robust across people. Of course, you're going to have individual variability with that response. But so we got the idea from an old paper I think it was in Circ. Geez, don't quote, I'm going to butcher the Somers, S-O-M-E-R-S, I forget the first name. And the idea there was to use low-dose dopamine to treat forms of periodic breathing, so sleep apnea and heart failure, so people that have sort of a heightened carotid body sensitivity. And yeah, so it's fairly robust across people. How sustained is it? So that question, I forget the washout now, but geez, you're asking about the pharmacokinetics of dopamine. I can't really remember. But I think it's several hours at least that you have to wait before. I think it was at least 5 hours, so 5 half-lives before we could move on to something else.
Okay, maybe you and Devin can kind of chat more in the Q&A tool. I have another question from Yanni Boutin, and sorry for butchering the name. The SaO2 was lower with prior hyperventilation at onset of IBM, but not at the end. Was there a difference in onset time of the IBM?
Yes, there was. And so the IBMs are largely related to the carbon dioxide levels. So it's important to emphasize here that these elite divers, they still have all the normal sensory afferents that are happening, the sensory afferents for the control of breathing. So they still do have the chemoreception coming in. And in the naive breather, so that involuntary breathing movement is largely determined by levels of carbon dioxide. And so the IBMs were delayed with prior hyperventilation because the carbon dioxide levels were lower in that apnea. Yeah.
Okay. And then I guess a potential, not to raise a doping strategy or a doping question, but if the respiratory muscle kind of feedback and the lung collapse is kind of driving breath hold and kind of forcing to break a breath hold, mm-hmm. Is there kind of some potential, whether from a scientific design, to really test that by whether reducing the amount of kind of respiratory muscle feedback? And obviously then it just becomes a question of, is that being done by anyone to try to prolong their performance?
Yeah, so you're asking for secrets, and I suppose I'll give you one. You don't want to delay the diaphragm feedback, because then you run into the risk of atelectasis or lung collapse. And the divers are actually really worried about that during the hyperoxic apneas. I think that's one of the reasons why ADA doesn't consider it a recognized discipline. But so what you can do though is, and I think this is what Budimir did, instead of using 100% oxygen, use, I think it's closer to 80% oxygen, and then have the rest nitrogen or some form of an inert gas, helium, something that's going to act as a stent to keep the alveoli open. And so, because you're running the risk of absorption atelectasis with 100% oxygen. And so I know the divers now are, at least I think this is what Budimir did. He didn't do 100% oxygen. He put in a bit of an inert gas to basically stent those alveoli open. And he was still euoxic at the end of the breath hold.
Okay, fascinating. So thank you so much, Tony. And there's a basic question from Lewis Halsey, if you could answer that in the Q&A tool during the second talk. But sure. I'll introduce Alex Patrician. Again, he's a PhD student in Phil Ainsley's lab at UBC Okanagan. And he's going to talk to us more about the actual deep breath hold diving. So Alex, if you want to take over.
Sure, thanks, Stephen. Let me just get my screen up here. All right, hopefully we can see that.
Yep, you're good.
Perfect. Yeah, so I guess I'm just kind of gonna build upon what Tony's talked about and about breath holding breakpoint and hypoxia, and kind of extend that to deep diving, because the same kind of inputs are still happening in these divers. It's just now they can't break their breath hold whenever they want. They can only break the breath hold once they've reached the surface. And so deep diving has another element of, I guess, risk, in the sense of you have to be, I guess, willing to make it back. The depth that you go to means you have to go the same distance back. So there's a lot more safety measures, especially in competition, where divers are kind of will only go as deep as they feel, and they've done a lot of training dives to progressively get deeper and deeper. And they're always listening to those warning signs that are going off to try and mediate any sort of, make sure that they can come back to the surface and still have enough oxygen left to get a white card, not black out, and be able to dive the next day. And so this is kind of some of the work that we've been working on with some of our Croatian colleagues as well, the same group Tony's been working with. And so, but more focusing on, and the talk that I'm going to be talking about is on the lungs and how deep diving can affect the pulmonary vasculature. And so I guess it all kind of started, at least for me, in the sense of I was lucky enough to go to the 2015 World Diving Championships in Cyprus. And it's kind of one of the IDA sanctioned events where the divers from all over the world go, and this is like the World Championships. It's basically the Olympics for these divers. And so the depths that these divers are going to, well over 100 meters, we have to be 5 kilometers, 10 kilometers offshore on a huge barge and boat that has all these dive lines set up. There's a huge safety team. And these divers this is their arena to compete, and there's no spectators really, because the boat's too small and you can't have boats around. Because obviously if anyone's put their head underwater, when there's a boat going by, there's that loud noise and the divers kind of need some quiet to concentrate. So kind of this little boat, you can't even see it from the shore. I wish I had a photo of the shore, but there's this little speck of a boat, you can't even see it. And this is kind of where I realized that, or I experienced kind of, not personally, but seeing the divers after performing some really deep dives, a lot of them came up with kind of lung injury, and they would be kind of coughing up blood. And even some cases, I remember one diver coming to me and showing his palm, and it was just a clump of blood that he'd coughed up. And obviously kind of, this is known as lung squeeze, but up to this point, and even kind of still today, there's still a lot we don't know about lung squeeze and how deep diving can affect the lungs, and at what point does it become injured, and how do you kind of protect against it. And so just so I can familiarize the picture here. So the picture on the right is just the side of the barge. So all these lines that are going into the water, these are like the practice lines. And so the main competition line is at the back of the boat. And so divers have a certain amount of time to warm up. They do shallower dives, and this is all to kind of just prepare themselves mentally and physically for their attempt. So so lung squeeze. There's a number of forms of pulmonary barotrauma. We all know kind of the pulmonary barotrauma of the inner ear, or of the ear, when we go to the bottom of the swimming pool. Now, we don't have trauma, but we can all feel the pressure in our ears, and we need to equalize. Otherwise, you can have a ruptured eardrum, and I'm sure quite a few people have had that. And so the aspect about the ear is that we can equalize. We just repressurize our inner ear so that it equals the outside pressure, and now our tympanic membrane is not collapsing in. Now, for the lungs, there's no way to kind of equalize it. You can't do anything. The lung is gonna decrease in volume, and even as early as like the mid 50s, even this is a study from Craig back in 68, where they were talking about the theoretical limit of deep diving being around residual volume, where your lung volume decreases in volume so much that you now reach residual volume, and that is your kind of limit. But then divers are able to go deeper, and some of this record is of 60 plus meters, and this is kind of when this discussion started happening about what is it about, like, residual volume theoretically sounds like that is your limit, but obviously divers can go beyond that. But with, I guess, looping back to lung squeeze and what it is, it's basically a pulmonary hemorrhage where there's now blood fluid in the lungs because of a tear that is now causing you to have impaired gas exchange, your inability to reoxygenate post-dive, and that scar tissue, and that's just it can be a very dangerous situation. And the only death in competition was due to a diver suffering repetitive squeezes leading up to a competition, and then having a squeeze on a dive, and they were unable to reoxygenate post-dive, and they ended up passing away. Now there's a range of severities. There can be a very light squeeze or mild squeeze, all the way up to severe, where your lungs are full of blood. And it kind of ranges with dyspnea, so difficulty, unable to catch your breath. There's tightness, irritation in your chest, and all these symptoms are kind of what divers don't want to experience, because it really impacts your ability to dive the next day, or kind of dive in general. And so kind of building upon the notions of diving deep is that the lung collapses or that the lung gets compressed. And because we can't equalize it, it will continue to compress based off of the hydrostatic pressure of the water column above you. So the deeper you go, the more weight that's above you compressing all your tissue, and the air-filled cavities are the most susceptible to barotrauma because they will decrease in size. And so this is a nice modeling study by Fitz Clark, where he modeled a lung across a dive to full collapse. And so you can kind of see that once the diver reaches about 18 meters, some of the most peripheral or basal alveolar units begin to collapse. And then progressively as the dive goes along, more and more units become collapsed, up to the point about 235 meters is the postulated depth at which the lung is completely collapsed. And so kind of with deep dives, this is kind of a notion of like, well, obviously we know going beyond residual volume can be done and is done regularly, but at what point, how much can the lungs handle? How much compression can the lungs handle? And so even since the early 50s, been a lot of studies looking at, or not maybe kind of more observational studies where they measure divers post-competition or notice divers come up and they're spitting up blood and they've suffered some sort of squeeze. It wasn't really until Lindholm in 2008 where they kind of experimentally tried to address this, and they got 11 divers into a swimming pool, and they had the divers fully exhale and reverse pack. So it's kind of it's the lung packing maneuver, but in reverse. And how it works is that you basically, if I was to pack air, I can't do it myself, but you close your epiglottis, you suck in air with your lips, close your lips, open your epiglottis, and force the air down. And so it's kind of like a kind of technique. And it's when you're reverse packing, you can pull air out of your lung even more. So you can go down to residual volume, full exhale, or around there, and then exhale even more air. And so these divers would go to the bottom of the pool, maybe 5-6 meters, and sit there at full exhales to kind of simulate a dive over 90 meters. And so that's a really nice, safe way of doing this rather than going out in the sea and getting these divers to go to absolute max, to kind of look at how lung compression or the degree of compression can affect lung squeeze or pulmonary barotrauma. And so these divers drove for 20 minutes, just a normal training routine. And this is typical for divers, they do in training anyways. And so they did laryngoscopy and found that there was blood in some of the divers, and that was originating from below the vocal cords. And this is an image from one of the divers. And some of the other symptoms that they found in some of these divers was like a cough was in some. There was some subglottal swelling and redness in the divers. All the divers seem to have a change in their voice post-dive that was only transient. And there was decreases in FEC, FEV1, and forced expiratory volume over forced vital capacity. So kind of nicely illustrating that the degree of compression can, and obviously going beyond residual volume, has an impact on the prevalence of lung squeeze. And then to go further on this point, even though the study happened before, this is a case study where in 3 divers, and let me back up again. So when you hold your breath for a long time, especially if you reverse pack or fully exhale, your point at which you become that urge to breathe happens a lot sooner, because you don't have full lungs, you're kind of collapsed, you're already like, you feel like you're about to explode even within 30 seconds. And so the occurrence of involuntary breathing movements happens a lot faster as well. And so the study by Kian kind of linked in the notion that not only is it the compression that is happening, but when you are holding your breath for a long time, or when you're diving deep and have what would be associated with a deep dive, this kind of breathing movements that happen can also affect the pulse pressures within the lung. And because the thoracic cage and the thoracic cavity is changing with each involuntary breathing movement, which progressively increase in amplitude each with prolonged breath hold, that these can also was common among all the breath holds all the divers who had lung squeeze. And so the theme of this talk, and I'm kind of going through, is just addressing different factors which can lead to lung squeeze and how we can evaluate lung squeeze, and even in the absence of, and how it affects pulmonary gas exchange. And so kind of just, this is a slide we'll see again. So we have lung squeeze, it leads to pulmonary hydrogen edema, and that impairs our pulmonary gas exchange. And so the two factors we talked about already is kind of exceeding the compressibility or the compliant nature of the lungs, so that then injury can occur. And then we also know from the case studies is that the strain associated with involuntary breathing movements can also kind of exaggerate this kind of lung squeeze or increase the risk of getting a lung squeeze. And so this is kind of, Tony touched just a bit on this already, on the kind of the depth records that we have, and there are a number of different disciplines. But obviously, as you can see, the records we have are well beyond residual volume, and so these dives would have been symptom-free. There would have been no issue, because when the diver comes up, they have to perform a safety protocol, and if you are at all unable to meet those protocols, then it's not a successful dive, and you'll get a red card or disqualified. And so I guess the fact that divers can go super deep, and just to kind of highlight, there's a number of different disciplines within the deep diving. And so CNF is a constant weight discipline. So whatever weight you have to bring back up with you. And so there's obviously a balance of buoyancy you want to keep in mind, but CNF is no fins. So these are divers who have no fins on them, and so they're using their arms and legs to swim down. And so the record's 102 meters, which is pretty incredible given how that there's no fins involved. Constant weight with fins is a bit deeper, say 130 meters, and that's the record Tony touched on. And then there's the discipline of no limits, which is, as long as you hold your breath, how you go down and how you come up doesn't really matter. And so most divers use a sled of sorts. And kind of this discipline received a lot of attention back in 2000-ish, when there was some bigger accidents where, up to that point, a lot of the divers would use a weighted sled to go down, get to the bottom, and then they fill an air tank at the bottom, and that's supposed to propel them back up. But there was an accident, and the diver got to the bottom of 160 meters, goes to fill the air tank, and there's no air. There's not enough air to lift them up. So that obviously, unfortunately, didn't turn out well. But with the current record of 214 meters, this is a motorized winch sled that goes all the way down and all the way up. And that was by Herbert Nietzsche in 2007. He again attempted 253 meters a couple years later. He reached the bottom, got to the top, but suffered a number of strokes and decompression sickness. And basically, there's actually a movie out on him. He had to learn how to talk, walk again, because whether the setup, he didn't receive hyperbaric treatment soon enough, or basically had a number of strokes and had to recover. But he's now back diving, and obviously not to the same level he was before, but there obviously is a limit to deep diving, and whether full lung collapse or whether it's the risk of decompression sickness, and it's hard to tell. But I kind of diverged a bit, I'm kind of getting off topic, but so we talked about compression, and this is just a simple diagram showing that the volume of a gas, so we can imagine this line here is our lungs. And so at the surface, we have a full lung capacity. At 10 meters, due to the hydrostatic pressure, there will be a halving of lung volume. And then as you dive deeper, the volume gets less and less and less. And so there's this compressive aspect during descent, which plays a big role in lung squeeze risk. But then another point is to what happens on the reopening, because if lung units are collapsing, is that playing a role as well? And so this is the same study by Fitz-Clark in 27. So it's a simulated modeling study. And so just to orient everyone, imagine each one of these lines is an alveolar unit, kind of representing different sections of the lung, kind of more apical to basal. And when these lines reach 0, it means that that alveoli has collapsed. And so there's quite a few alveolar regions which are predicted to collapse fully during a course of a dive. And they contrast with the more apical regions, or the alveolar regions that don't collapse, in the fact that when they decrease in volume, they reopen at the same rate. And so the lung volumes that do collapse, and I guess this is more apical and basal, the way he's oriented at this is because the no limits diving is done like in the upright position, because they're kind of strapped on a sled and they're going to be going up and down. And so the tricky thing about when the alveolar units collapse is that the adhesive forces or the surface tension keeps them closed. And so when the diver starts ascending, the drop in ambient pressure, which allows the uncollapsed alveoli to reopen, it isn't enough to overcome that adhesive force. So the alveolar units don't open until the point when the ambient pressure, the hydrostatic pressure, has decreased enough that it now overcomes the adhesive forces. But now, because there's such a disconnect between the required pressure to open it and the required reduction in ambient pressure to what it is right now at that phase of the dive, there's a huge discrepancy between that. And so now, to compensate, the alveolar units will pop open and rapidly kind of adjust to that pressure difference. And it's this kind of abrupt alveolar reopening, which you can kind of see here is another aspect which just looks a lot like a reason for an injury to occur as well. And so if we kind of add this abrupt alveolar popping as another risk factor for lung squeeze, given that there's just going to be all these changing mechanics in the thorax happening at the same time. And so kind of, this is where we kind of start off from with some of the studies that we were running off of. And so what we wanted to evaluate was, is the end goal of kind of a dive is proper pulmonary gas exchange so you can reoxygenate. And if you have a lung squeeze, there will be impairments to that pulmonary gas exchange. And so we wanted to evaluate what is the normal situation in normal divers who are in the absence of lung barrier trauma. And if we do see divers who have lung squeeze, what is their impairment like, and how long does it last? And so this is kind of, like Tony said, we're totally indebted to our Croatian colleagues who, without them, we wouldn't be able to perform this research. And they're the diving coaches and kind of the leads on the Croatian front. And kind of we were able to work with them to try and address some of these questions. And so the tricky bit about evaluating deep diving is that you can usually go in a hyperbaric chamber, and there's been some studies that have done that. But being able out in the middle of the seas is it brings a whole other logistical requirement to it. And that's what we were able to do in Croatia. The water was deep enough. We had divers, coaches, the safety staff. We had a platform set up to kind of address how deep diving affects the lungs and pulmonary gas exchange. So here's our main diving platform. There's electrical winch on it. You can see all the different dive lines. And then there's some other dive lines where there's multiple dives around. So everyone's watching each other. And this is kind of the setup that we had for divers to warm up on and then perform their dive on the platform. And since we're in the middle of the sea, we need a laboratory. So we have one of the boats that was the owner of the hotel that we were staying at. And so we had a generator on the front of the boat to kind of power all the electrical things we had. We had a bed in the back. There's also a bed in the cabin in the boat, but I'm not sure if anyone's been in a cabin in the waves. It's quite, it tosses your stomach around. So we were able in the back of the boat to do the measure. So the divers would do their dive, come to the boat, and we would scan them. And we're, depending on the depths of the dives that we were looking at, we could be anywhere between shortly, like fairly close to shore, or even five kilometers offshore to get some of the really deep dives, which I'll kind of touch on later. And so this study was kind of conducted over 2 summers. So it's a kind of a collection of different methods. The method that was always kind of done was pulmonary gas exchange efficiency, which I'll kind of go over next, ultrasound B lines, and then we did an underwater electrocardiographic unit. We could measure ECG and track pressure. We did some airway resistance and reactance using flow oscillation technique. And we did some pulmonary pressure measurements, and we did lung volume at baseline. And so kind of the basic protocol was that we would measure divers at baseline on shore, go out to sea, have them perform their dives, and then we measure them at time points post-dive to try and time course how pulmonary gas is exchanging and what is attributing to that impairment that we might see. And so one of our main variables was pulmonary gas exchange, and there's a device that's been developed. The company an idea from John West is a non-invasive approach to evaluate gas exchange, and so they've been able to, using some algorithms and correcting for CO2, to calculate the arterial PO2 based just on the expired breath and the pulse oximetry. So we have pulse oximetry to get SpO2. They use the end-tidal capnograph to adjust for the shift in O2 affinity. And then they compare the end-tidal O2 with the calculated arterial to give us this alveolar to arterial pressure difference of oxygen, which is they've referred to as the O2 deficit. So a higher deficit means that there's a larger difference between the alveolar PO2 and the arterial PO2. And given there are a few assumptions you have to make, the requirement is that the subject is breathing at a steady state. So we can't just take one measure on one exhaled breath, because we need a steady state to make sure that the CO2 is steady, the O2 is steady, the SpO2 is correct. And so there's kind of we need a minute or so of recording to get a steady state, and then we can kind of extract that time point as our value. And there's been a number of validation studies to go over O2 deficit and comparing to our arterial blood gases. And there's been a really nice connect, and obviously between O2 deficit and the alveolar to arterial gradient that's performed invasively. Ultrasound B lines is a technique which uses basically looks for artifacts in the lung, or changes in density. And if anyone's not familiar with scanning the lung using ultrasound, if in a normal otherwise lung, you wouldn't see anything. It's just blank. But any increases in kind of changes in artifacts, if there's like fluid in the lungs, and that will be a change in density, which the sound waves from the ultrasound will pick up, and it will kind of show up as a streak, like a comet. And this comet will kind of move across the screen. And so when we evaluate the lung, we divide the lung into 28 zones, so 16 on the right side and 12 on the left. And going through each zone, we count the number of comets we see. And comets have been linked with extravascular fluid accumulation. So if someone has pulmonary edema, you would see comets. And so on the bottom of the screen, you can see that if someone has comets in zone 1, and you go through all of them and you count up all the comets, they'd have 16 comets at the end. And so this kind of increase in comets is that associated with a decrement in pulmonary gas exchange. And even now, I guess this is not advanced imaging, but so anyone, the comets are common among people. Usually less than 5 is deemed clinically insignificant. This is just to kind of touch on what we've done. So this airway resistance and reactance is basically a non-invasive way and a simplified way of doing lung compliance measurements. So we didn't have a box that we could have the divers go in. And so this uses sound waves to look at the different properties of the lung. And so there's different stimuluses that is applied, and it's just do normal breathing. And you can kind of quantify the resistance and reactance of different airways, from small, medium, up to large. And so some of the results that we had, this is the main kind of all the dives we had. So we had 16 divers dive about 50 dives to around 60 meters. And so some divers dove multiple times. You can kind of see how the overall there was an increase in O2 deficit immediately post diving, which kind of seemed to resolve down. And there's quite a big range in dives. Some divers have a big deficit post dive, and other divers did not. And if we just plotted the O2 deficit with dive depth, you can see that there's quite a nice relationship between the level of impairment and the depth at which they attained. And that kind of aligns with the compression that would be happening, especially if there's any IBMs or they become hypoxic, if there's, and then the reopening, because a lot of the dives were below residual volume. But we wanted to kind of evaluate that and see if we could divide divers based on their depth on their lungs. And so we were able using, so we did lung volume measurements at baseline, so we could calculate what each diver's residual volume depth was. And based off of it's just if you use Boyle's law, and we have a pressure at the surface and pressure at their max depth, and then their surface volume, which would be their total lung capacity at baseline, we can then calculate their volume at their depth. And if that was less than the residual volume or greater than the residual volume, we can kind of group divers by that way. And so when we do group them that way, it does seem that the divers who are diving below residual volume, so deeper, and so the more compression beyond residual volume, have a greater impairment gas exchange. And this is kind of just another way of looking at the very similar data in the sense of does diving below residual volume result in more O2 deficit? And this is kind of to quantify how much below residual volume are these divers diving. And so this kind of RV reserve is meant to kind of highlight if the value of 0 means that the diver dove to residual volume. That's the lung compression equal to the residual volume, and then they went back up and it opened up again. So if it's a plus value, that it means that they didn't reach the residual volume. If it's a negative value, it means they went below residual volume. And so the red dots are the 9 minutes and the blue dots are at 2.5 hours. And this is just like how we're able to calculate it. It just shows that the deeper the dive usually meant that there was a greater impairment in gas exchange, but not always. And we'll go over that next. Some of the data when we collected, this is from the 2018. So this is part 1 of a part 2. There was some increase in B lines, which we didn't necessarily see with the other study, but there's some potential reasons for that. And we also did the pulmonary systolic pressure, which didn't change across the dive. So I mean, we weren't able to evaluate during a dive, and the changes during a dive are likely what's relevant and important, but we weren't able to see whether there's any persistent pulmonary hypertension that's happening after a dive. We saw subtle decreases in air resistance and reactance, but these values weren't. There wasn't anything outside of normative ranges, which would be associated with a clinical population, and so that story is also a bit, still I need to look at that a bit more. So we're back kind of at our main summary slide of kind of lung squeeze and the factors. And so in normal dives without lung squeeze, we do see an impairment in gas exchange, but this recovers within a few hours. And so this is kind of our comparative standpoint. And now we want to, did we see any divers who had any lung squeeze, and how long did it last? And so we had one diver during the study who went on a dive after the data collection and suffered a large severe squeeze. And so this diver is very well trained. The only feature of this diver was that they were relatively new. So they'd been in the sport for maybe a year or 2 years and had progressed really quickly. But they had all the techniques, they were diving really deep. And so this dive to 91 meters is what they reached, but they had a very severe lung squeeze. They're coughing up blood, they had tightness in their chest, and a really strong dyspnea, and really not in a great spot. And so when we did the pulmonary gas exchange measure, we could there was a huge impairment in pulmonary gas exchange. And the notable thing about this measurement was that it wasn't done immediately post-dive. It was done 4 hours after the dive. And so this persistent impairment from this rupture and the hemorrhage in the lungs has really led to like a long-term or a persistent kind of decrement. And this diver also identifies as self-squeeze. So whenever they dive, they regularly experience symptoms. And we can't, and it's just like high altitude pulmonary edema where individuals are susceptible, but predicting it in the sense of prior experience. Without prior experience, it's hard to know which divers are, and kind of one interesting feature of this is whether this follows a similar kind of pattern that high altitude pulmonary edema does in the sense of susceptibility. Is it similarly mediated similarly? And so if we have a squeeze, there'll be obviously severe impairments, which last for well over 4 hours. And obviously, kind of adding to this figure, there's certain factors which could kind of augment or exaggerate kind of these alveolar reopening, IBM strain, and compressibility of the lungs. And susceptibility is definitely a feature which likely predisposes an individual more to lung squeeze symptoms. And so this is the same figure we saw before. I've just removed the 2.5 hour data points. And so the high O2 deficits at low lung volumes that are below residual volume are equivalent to O2 deficits seen in patients with lung disease, from COPD to pulmonary fibrosis to, and this has been shown with the same kind of unit in the clinical populations. However, one feature about this figure is showing that even though some of these divers went below residual volume, they didn't have any impairments in pulmonary gas exchange when they surfaced. So it's not that deep diving is the sole reason. There's obviously something else going on, and we kind of want to look at what is that. What about it is leading these individuals to dive very deep but have no decrements in gas exchange. And so kind of the notion of training status and adaptation comes into play. And so we were lucky enough to, when we were in Croatia, that some top world-class divers were there and were willing to participate in the study. And so we were able to get some measurements in divers diving beyond 100 meters and to kind of compare a well-adapted, highly trained group to kind of in our cohort. And so we have two divers, one dove to 102 meters and one dove to 117 meters. Dive times are different because of the discipline they performed, but both divers had almost 15 years of experience. So we're well in the sport and compete and are some of the best divers in the world. And so based off of the pressure, the underwater unit we had, we could track their the pressure across their dive, and then based off of their lung volume measurements on the surface, and accounting for lung packing, we could calculate their lung volume across a dive. And so for each diver, you can kind of see as the kind of lung volume decreases with the dive, and then I've highlighted the dotted line is their residual volume that we calculated. And so the red highlighted bit is the area of the dive that they go below. And a feature between the two divers that is the different fact is the amount of time they spent below 100 meters, 5 seconds versus 30 seconds for a diver two, and kind of why that's important I'll go over in a couple slides. and just to kind of show the lung volume, what their calculated lung volume would be at such an extreme depth. And so this is their pulmonary gas exchange and some other variables that kind of plotted on the typical alveoli circulation kind of diagram. So we have their untitled CO2, we have the alveolar PO2, arterial PO2, and they have mean arterial pressure, SpO2, heart rate, and the number of B lines, and their O2 deficit, which is the difference between alveolar and arterial. And so after immediately post dive, there's quite a noticeable impairment in gas exchange. And then by 2.5 hours, 3 hours, there was it had resolved, or it had mostly resolved, but it hadn't fully come back down to the baseline. And so even at such extreme depth, these divers didn't have the same level of impairment that the other diver who was susceptible experienced. And during this dive, they did experience, one of the divers had a bit of some irritation in their chest and some tightness and maybe a bit of specks of blood in their spit, but it resolves quickly. And so this is just plotting same figure before. We have O2 deficit on the y-axis and depth along the x-axis. And I've just highlighted the dives of the two divers, of the world-class divers, compared to the susceptible diver. And so obviously with deeper and deeper dives, there's a greater impairment, but even a susceptible diver doesn't have to dive as deep and they still get even higher impairments. And obviously as part of training, and these divers are well adapted, divers typically, to help manage their lungs tolerance to the compression, is they do different stretching techniques. So like the study by Lindholm, divers will go in the bottom of a pool and on reverse low lung volume, sit in the bottom of the pool and train their lungs to get used to that level of compression. And this is a diver doing different stretching techniques where they're trying to exaggerate any sort of strain within their lungs at elevated and low lung volume. So I even tried some of these stretching techniques and my back cracked when I tried to mimic them, and I was just breathing normal, let alone reverse pack and then perform some of these really aggressive stretching techniques. And this is all to kind of help improve the compressibility or the tolerance of the lung tissue. And so kind of have a very adapted situation with these two world-class divers. So obviously your level of training and adaptation can kind of buffer some of these factors which can lead to a lung squeeze. But the susceptible diver was also very well trained. So obviously being more susceptible is more of a stimulus, can play a much more important role. And so I guess from this point forward, it's kind of, there's a number of other factors which we need to look at. And because one reason we've hypothesized that we didn't see the beeline shift in immediately post dive. Well, basically one strategy that is kind of been hypothesized to help the lungs manage this hydrostatic load and compression is a phenomenon as a blood shift, where as the diver is diving, the centralization of blood from the periphery through peripheral vasoconstriction to kind of blood and kind of enters the thorax and the lung tissue to try and help manage the level of compression that is happening and the reduction in volume. Another factor which probably plays into susceptibility is if you have a previous squeeze, does that predispose you to more squeezes later? And then something we weren't able to evaluate because we couldn't, these were divers performing their normal training routines and we were just capturing their pre and post diving measures, but figuring out whether there's a difference in the type of discipline that divers are doing. So if there's no fins and they're using their arms and legs, there's a whole lot more thoracic strain that's happening using their arms versus if they're just kicking or not kicking at all in a no-limits discipline. And so these are kind of some of the questions that we still have to look at, and which probably explain why not all divers get lung squeeze when they dive deep, and that it's actually a multitude of factors which contribute to, at the end of the day, a diver squeezing or not. But I guess for divers' perspective, the biggest question that still remains to be valid is, when is it safe to dive? Because right now we don't have any safe return to dives guidelines. There's not much of a, obviously divers want to rest after they squeeze, but how long do they need to rest for? What rest does that entail? Are they limited now in their depth because they now have improper healing? These are all kind of questions that we still have to answer, and kind of will be looking to look for it in their upcoming studies. I'm not sure what's my time. I guess a couple quick, just one very quick point on deep diving is there are a number of risks aside from just the lungs. When the deeper you go, the longer your dive time, the more likely you are to become hypoxic when you surface again. But there's also, when you're at depth, because of the pressures, there can be facilitation of the nitrogen that's in your lungs, which is normally inert when we're breathing up on the surface, but that can enter the bloodstream and cause narcosis and maybe even lead to decompression sickness. And kind of thinking back of the rate at which, when lungs become fully collapse, that's kind of where this plateau region happens, and the risk of narcosis and the risk of decompression sickness, because I mean the lungs are completely collapsed now. So there's technically no more nitrogen left in the to diffuse over. And there's a comparative Punganis who had a nice line where how the humans, we take a big breath to dive deep because we need all that oxygen. That's our greatest store of oxygen, is our lungs. But a big proportion of that is nitrogen when you take a breath at the surface. And so even though it's our necessity to hold our breath or to take a big breath in, that's animals don't do that. They usually breathe on they exhale before they dive, and they have collapse very early. So just a comparison. And 100 meters kind of defined as the risk of decompression sickness increasing. And that's just based off of the partial pressures of the gases, which with compression, a reduction in volume, they exponentially increase. And so nitrogen can get really high, CO2 can get really high at max depth. And then when you resurface again, the reverse happens. And so both of our divers had nitrogen narcosis. One, since they were only 5 seconds at below 100 meters, they only had very mild symptoms, which dissipated quite quickly. But the second diver, given they spent over 30 seconds below 100 meters, they were very, like amnesia was kind of a prominent feature when they surfaced, and for quite a few minutes, 10, 15, even almost 30 minutes until they were totally back to normal, they kept remembering more parts of their dive. Like, oh, they remember now what happened. And it was a very strange kind of seeing this in a diver who's extremely experienced, but having these symptoms. And there was no like joint pain, skin pain, dizziness, loss of vision. That would kind of suggest decompression sickness. So it's just a feature of deep diving that is kind of believed to only occur in scuba diving, but given the depths that divers are facing, and this is just venous blood samples from studying the AMA, performing repetitive dives across a day, and you can see the partial pressure of nitrogen in the blood is quite a bit higher during the dives, and then it obviously contributes. And so linking narcosis to decompression sickness is an important aspect given how deep these divers are going. And obviously the repetitive nature allows more accumulation and the less clearance, and especially spearfishers, safety divers, especially those using scooters, because they can ascend much more quickly. And obviously with nitrogen circulating, you can have bubbles, and obviously that can lead to stroke. So in summary, just diving deep can play an important role in pulmonary gas exchange deficiency or impairment, but this usually resolves. Squeeze is a complex injury, and there's a number of factors which can play in, and so it's a multifaceted risk. And then nitrogen narcosis, bubbles, and decompression sickness can occur in breath-hold divers, and being aware, and it's kind of just debunking that, I guess, myth, even though if people still thought that before. So yeah, that's pretty much it. Thank everyone involved. There's a big team from Croatia, from our international collaborators, and our team here at UBCO, and the Croatian coaches and all the divers. So yeah, can happy to take any questions.
All right, thank you, Alex. And quite the unique and nice experimental platform out there on the boats when it's, at least when the water is calm. Anyways, and lung squeeze certainly doesn't seem like anything I ever want to experience. The one question I had is somewhat naive question, but do you see any evidence of kind of risk for lung squeeze in kind of the distance breath hold divers? To kind of look at it, they're both exercising, kind of the depth divers and the distance divers, and they're obviously both holding their breath, but the big difference is one has depth as an added stressor. So is there any evidence for any of these problems in kind of distance divers?
Yeah, that's a good question. I mean, with the dynamic disciplines of the horizontal, you have the divers that are going to the complete, they're having IBMs, they're severely hypoxemic, and they're exercising at the same time. And I'm not aware of, I'm sure there has been maybe some evidence of it, but most of the evidence on lung squeeze and the injury to the lung is with the depth, because it's not only are you exercising, and when you're coming up from a deep dive, you have to overcome your negative buoyancy. So it's a lot more effort. You're not going to float up. You have to overcome that negative buoyancy until maybe 20 meters, and then you'll float again. And so it's just kind of the compounding effects of the compression, which you're under, any involuntary breathing moves that you have. There's the whole, like you're hypoxic. And so just I think it's more most of the evidence is in deep diving that if this occurs. And then not necessarily, it doesn't have to be deep. It's maybe just more on, well, deep to us, obviously, but it's maybe a number of factors that go into it's the hydrostatic load, I guess. Yeah.
Okay, and I have a question here from Ben Stacy. Do these divers present with any hematological adaptations, such as increased hematocrit or hyperviscosity? And would they benefit from increased hemoglobin, or is this likely to predispose to blood-brain barrier disruption? Should we be teaching Sherpa to hold their breath?
Well, that's a good question, Ben. That's a very integrated question, but yeah, I mean, some of the data in divers, we didn't collect any blood samples, and that's something we want to do in the future. But Tony's done some kind of blood analysis and blood-brain barrier markers, and kind of evaluating the risk of the impact of severe hypoxemia on cerebral blood-brain barrier and dysfunction. And so you can probably speak to that a bit better. But yeah, the adaptations regarding like whether splenic contraction and blood volume and circulating O2 stores and managing that is definitely probably something that these divers also have on the rest of us and that enables them to do that.
Tony, anything to add to that?
Yeah, it's a good question. I think they do have some slight hematologic adaptations. Hemoglobin's a little bit higher in these guys, but nothing like you'd see with the Sherpa divers, the adaptations you get at high altitude. The spleen contraction is an interesting one. Blood-brain barrier disruption, you don't really see it, at least acutely. I'm sure though that, especially just with the increased cerebral blood flow. So there's, if you're doubling your cerebral blood flow, just the hydrostatic pressure inside that capillary. Now, mind you, your intracranial pressure is also increasing, which slightly reduces the inside minus outside pressure, which is the transmural pressure, which really matters for blood-brain barrier leakage. But yeah, I don't know, breath holds with Sherpas, it's an interesting concept. What I would be more interested in is getting the breath hold divers up at altitude. and see what they can do. But yeah, it's a cool question. Maybe we should get the Sherpas down at sea level and do some breath holds, see how they do.
Yeah, and I guess the other thing that came to mind too is in terms of what Alex you're really talking about is kind of the real extremes of depth, and kind of the way I almost look at it is it's almost like the kind of the power lifters or the sprinters, whereas kind of you brought up the AMA at the end where they're doing this all day and doing shorter and shallower breath holds, but repeatedly and probably not to their limits. And it's almost the analogy I'm almost thinking is they're almost like the endurance athletes, the long distance runners. But yeah, I'm assuming there's been no work done on that population of kind of repeated kind of a shallower breath holders.
It's interesting, if you look at the AMA, they actually have, at least from the limited data that exists, they have improved cardiovascular function. And it just, I think it's arterial stiffness is lower in these AMA. And so, yeah, I would liken it to the endurance runner as well. Their adaptations are definitely beneficial. They're certainly living longer. But might just
and like the divers are living, like they'll continue diving till they're well over 90 in some cases.
Yeah, Budimir is, he just got the record for the hypoxemic breath hold. I think he's 60 now or something. He looks like Rocky.
Yeah, it is.
Yeah, so as far as we know right now, notwithstanding those extreme depths, especially with the no limit disciplines, as far as we know, there isn't, at least with the AMA divers, there isn't really any long-term consequences that we'd be worried about. But I mean, there's obviously a caveat to that. There could be some,
like, I guess, and like kind of extending what Tony said, it's really hard to compare the AMA divers to these like competitive free divers because they're such different,
completely different. Yeah,
the AMAs are like, that's a lifestyle. They're not diving to max. They're searching for food, versus the competitive divers that are performing all these crazy stretching, extreme dives, like to the point of blackout, and it's like it's a tricky comparison, but it's like what we have to compare against as a long-term kind of, and even other populations in Indonesia and Korea, and those ones are, especially Indonesia, is a lot harder to get to, just they're remote, but yeah, it's a cool thought.
All right, and in the interest of time, I'll end this session. I want to thank both Tony and Alex for really intriguing thoughts and ideas that probably many of us hadn't really thought about before. Just what happens at depth. A lot of the work has been on kind of scuba diving, but in terms of this breath hold, it's great that you two are kind of really leading the way and pushing the envelope in terms of studying this really unique environment. And I'll just close off with, again, thanking both our speakers, now adding them both to the Wall of Fame for this session. And again, just want to remind you that you can be registering for next week's talk already at ICE 2021. I'll have that up kind of later on today, the talk from Alex Hutchinson on science communication. And again, all of the past talks, including this one, we'll have up on the website and on the Environmental Ergonomics YouTube channel very shortly. So I want to thank all of you for attending. I want to thank again Tony and Alex, and we will see you in 2 weeks' time.